Cancer Center in New York City, and the authors and I have no conflicts of interest to disclose. So our study evaluated health-related quality of life in patients with facial cancers that ranged from less severe cases of skin cancers, such as basal cell carcinomas, to more advanced cancers of the head and neck. Our faces are a distinguishing and very integral part to how we define ourselves. With this in mind, changes to the face due to treatment of facial cancers often affect health-related quality of life. Specifically in relation to the face, this is a multidimensional concept, and our patients reported changes in facial function, psychosocial well-being, changes in social activities, physical symptoms, and they also addressed the importance of expectations and satisfaction with care. In terms of the importance of studying these patients, I want to touch a little bit on the rate of diagnosis and a little bit of epidemiology. So the incidence rate of skin cancers provide a clear rationale for the importance of the study. Skin cancer cases have been on the increase for the past 3 decades, and head and neck cases have seen a slight decrease in some populations, but have only slightly decreased in general. So this graph shows the U.S. rates of head and neck cancer incidence from 1989 to 2009. And as I mentioned, we do see a decline in African American populations, but only a slight decline and then a leveling out overall. Tobacco and alcohol use are still the most important risk factors for most head and neck cancers, but certain types of HPV can also contribute to onset. An estimation of $3.6 billion are spent in the U.S. each year treating head and neck cancer. In skin cancer incidence, we see an increase in both Caucasian populations, which is typically the affected population due to the fair skin tone, and an increase overall in both women and in men. To provide a little bit of context to these graphs, today 3.5 million basal and squamous cell carcinomas are diagnosed every year. From 1970 to 2009, we've seen a melanoma increase by 800% in women and by 400% in men. From these numbers, in both populations, there is a clear need to better understand the health-related quality of life concepts that are important to both patient groups. So we analyzed our sample in 2 categories. We had the advanced stage head and neck patients and the cutaneous skin cancer patients. The goal in mind here was to compare the qualitative findings, looking at similarities and differences of the 2 groups. So our overall objective was to conduct a qualitative study in order to better describe how altered facial appearance impacts patient satisfaction and quality of life following a range of surgical treatments for these 2 different groups of facial oncology patients. So when I say head and neck, this includes any cancer that occurs in that region. It can be skin, oral, or soft tissue. We wanted a diverse sample, so we recruited patients with different demographic variables such as age, race, and gender in mind, as well as different treatment regimens such as surgery, chemotherapy, and radiation. This group of patients, as you can see in the images, often experience obvious facial changes in both facial function and in facial appearance. In terms of the skin cancer group, we recruited patients who had the 3 main types of skin cancer. Firstly, we have basal cell carcinoma. This is the most common type of skin cancer. It's superficial, it's slow-growing, locally invasive, and it rarely results in metastasis. Secondly is squamous cell carcinoma, which generally occurs in areas of the skin that have been overexposed to the sun. So when you're on South Beach later, bring your sunscreen. These are 2 non-melanoma skin cancers. Thirdly, there's melanoma, which is the most severe skin cancer diagnosis and usually involves more intense treatment compared to the other 2. Generally speaking, though, this population does not experience changes in facial function the way that the head and neck cancer patients do. The changes here are more appearance-focused. So overall, we had 41 patients, 26 were head and neck, and 15 were skin cancer. The data was collected over a period of 5 years. In terms of methodology, we used a qualitative approach. Patients were asked to tell their story and interview guides were used to provide a little bit of structure to the interview. The interviews were then transcribed verbatim, and the data was managed using Vivo qualitative software. We analyzed the interviews thematically using grounded theory approach and think aloud techniques as we worked through and encoded the data. So results. This table shows the demographic variables. Both groups had a mean age of about 58 years, and we also had similar ratios of males to females in both of the groups. In the skin cancer population, you'll notice that 100% of our patients were Caucasian, but again, this was congruent and expected in relation to the current skin cancer incidence. And then we have about 46% of the head and neck patients and 73% of the skin cancer patients who were married or in long-term relationships. The clinical variables show a breakdown in the diagnoses of our patients, and we were able to recruit participants in every main diagnostic category. Of specific interest here is that within the skin cancer sample, 40% had had prior skin cancers, and within the head and neck sample, 5 patients had also previously been treated for skin cancer. So there's a little bit of overlap and cancer recurrence in these populations as well. And finally, the results of methods of reconstruction. 15 of our head and neck patients had microsurgical flap. This means that a flap of tissue and skin was taken from an area on the body, such as the forearm or the thigh, and transposed to the area on the face or neck, which is the area of the defect. 11 of the patients had a local flap, meaning that the flap used was immediately adjacent to the area of defect, such as on the forehead or the cheek. Within the skin cancer group, 5 patients had a linear closure, which is the simplest closure, 8 had a flap repair, and 2 had a skin graft. To make this a little more clear, I have some pictures to demonstrate some of these procedures. So here we see 2 examples of a flap reconstruction. Sometimes, as with the picture on the left, there are issues with how the color of the skin flap matches up with the color of the facial skin. Other times, it is just that the scar is very visible or large. Here's an example of a scar from a linear closure. Again, it's a much smaller scar, much smaller area of defect, but it's still a visible change to the face, which was an area of concern for patients. So when analyzing the results from these 2 sets of qualitative interviews, we noted that there are obviously clear differences in the severity of treatments, from a minor linear closure for a skin cancer to a much larger flat closure for a head and neck cancer. But here's what's interesting. Despite the range in treatment severity, analysis of the data revealed that both groups of patients reported similar factors that affected, and by that I mean that they ameliorated or exacerbated the impact of facial reconstructive surgery or treatment. And we termed these factors mediators. Variables that function as mediators do so because they explain how external physical events, such as a change in facial appearance due to surgery or treatment, take on internal psychological significance for the patients. And we found 3 mediators that acted as such for both of these groups of patients. These mediators are cancer worry, expectations, and appearance investment. And this conceptual framework helps to more visually depict the model. So the blue lines represent head and neck, and the orange line represents skin cancer. I'd like to first bring your attention to the top 2 boxes of the model. The change in facial function was important for head and neck patients, but not as important to the skin cancer patients, which is why it's represented with a dotted line. Where we do see similarities in the bottom 2 boxes, in the change in facial appearance and the subsequent psychosocial impact of this change in facial appearance. And I want to go through each mediator just a little more closely and provide some examples. So first we have cancer worry. This mediator regards the concerns about cancer recurrence, and what is important here is that irrespective of the change in facial appearance, the severity of the change, both groups of patients commonly reported their ability to put their aesthetic concerns aside in perspective regarding future cancer recurrence, any concerns regarding that. One head and neck patient said, "The surgeons kept saying this is going to affect your appearance. Your skin colors may not match up, but when you put it in perspective, that was very trivial compared with the cancer continuing to grow." A skin cancer patient agreed. "I would say it, the scar, bothers me to like a 7 or 8 on a scale from 1 to 10. I go back and I think about it. I go back and I try to have things done to make it look better. I mean, would I rather have some scarring than to have the health repercussions of not treating it? I would always take a scar over health." Next, we have expectations. And what we found here is that participants with high expectations were more likely to be dissatisfied because there was a mismatch between their idea of what they expected the outcome to be versus what was actually achieved in the reconstruction. Head and neck patient said, "I was not prepared for the scars. I wasn't. I just assumed it would be a small scar. If I knew exactly what it looked like, I probably never would have done it, to be honest with you." And then a skin cancer patient said, "The scarring gets better all the time. It's diminishing, so now it actually meets my expectations." Along these same lines, we have appearance investment. This means that participants who cared greatly about their appearance before reconstruction were more likely to be negatively affected by the changes to their face afterwards. Overall, we see here that patients were very concerned with big picture changes, such as scars or skin color differences that impacted the asymmetry of their face following surgery or reconstruction.